think that we've known from our melanoma data that the immune therapy can enhance subclinical toxicity from other therapies. And we know that from ipilimumab dacarbazine, where we saw liver toxicity with that combination that we didn't see with either ipilimumab or dacarbazine alone. And who knew that dacarbazine caused liver toxicity? And so it's not a surprise that a drug that's not a very clean inhibitor of VEGF, such as pazopanib, which has liver toxicity, could have exacerbated liver toxicity when combined with something that enhances inflammation at the site of damage. And so our efforts, after seeing that initial experience with sunitinib and pazopanib being combined with anti-PD-1s, we try to focus on more selective inhibitors of VEGF. And that was either axitinib, which is the most selective of the VEGF inhibitors, or bevacizumab, the antibody that binds VEGF. And we've had a little bit more success combining anti-PD-1s or anti-PD-L1s with either bevacizumab or axitinib. I led a trial that was reported out at ESMO in 2016 combining axitinib with pembrolizumab, and in 52 patients, the combination was well tolerated with very little in the way of liver toxicity. Most of the toxicity was still related to axitinib rather than pembrolizumab, and the response rate was over 70%, and over 90% of patients had tumor shrinkage, and the median PFS was at least 15 months at that time. And that trial data led to 2 phase 3 trials, essentially. One that's ongoing of axitinib plus pembro versus sunitinib, and a subsequent trial that came out of Pfizer looking at avelumab plus axitinib versus sunitinib, both of which are accruing at the moment. But another trial was a trial looking at atezolizumab, a PD-L1 antibody, together with bevacizumab. And there was a small phase 1 trial which showed about a 40% response rate with the combination, an increase in immune infiltration in the tumor microenvironment in patients who had a biopsy before and after treatment, or before and during treatment. And so this led to a randomized phase 2. And at GU ASCO, David McDermott reported, Tom Pauls presented what was the first randomized data comparing a combination IO VEGF inhibitor to VEGF receptor TKI or to atezolizumab alone. And in that report at GU ASCO, there was actually no significant difference in PFS for the intent to treat population for the bevacizumab atezolizumab combination compared to sunitinib. But in the group of patients, which represented about half of the patients in the trial who had PD-L1 expression that was elevated on their immune cell infiltrate, which is the way Genentech does their PD-L1 assays, there was a doubling of PFS to 14 months for the atezo-bev arm compared to 7 months or so for the sunitinib arm, and a virtual doubling of the response rate. Interestingly enough, the highest number of CRs, complete responders, was in the atezo monotherapy. They took that study, had a heavy translational endpoint, and at AACR, Dr. McDermott presented some biomarker data from that subset, which was fairly interesting, where they did RNA-seq on the tumor cells looking for either an angiogenesis signature, a T effector cell signature, or a myeloid signature that were all predefined, and then divided patients based on the median expression into either high or low in those various categories, and looked at how the 3 treatments behaved in those categories. And they were able to identify that patients who received sunitinib actually and had an angiogenesis high signature did much better than the atezo alone arm, and that was not the case in the angiogenesis low. So that's the first time we actually have a predictive biomarker that could be potentially used for a VEGF receptor TKI. They also saw that the atezo-bev arm was the best in the T effector signature group, better than the atezo alone arm, even though there were some higher degree of complete responders in the atezo alone arm. But perhaps the most interesting data was in the group of patients who were T effector high and then divided into two groups based on whether they had a myeloid suppressor cell signature versus not. And in the patients who had T effector high, myeloid low, so less tumor infiltration with myeloid suppressor cells, there was good activity in both the atezo alone and the atezo-bev. But in the T effector high, myeloid high, so immunosuppressive, there was very poor activity with atezo alone, but that activity could be rescued by the addition of bevacizumab. And so the atezo-bev did very well in that group, much better than the sunitinib group, and it suggests that that's what bevacizumab might be doing in this combination, suppressing the effects of those myeloid-derived suppressor cells, and suggests that that combination may actually be working as an immune therapy rather than combining a VEGF inhibitor with a immunotherapy. And so it gives one a reason for potentially thinking about what you're doing with those combinations, as well as a patient population who might require that type of combination. And that's something that will be looked at in the phase 3 trial of atezo-bev versus sunitinib that has been accruing, I think completed accrual in October of 2016.